Welcome back, Richard. It's good to see you after taking a
Morning.
week off.
Right? Ready to go again.
Yes, this time I was out of town, so man, yeah, it,
July.
it, it just seems like we seem much busier than we are with some of these other things outside of the office. You know, but yeah, so I was out of the office away last weekend, and so we didn't get to record. But it's good to see you today.
Yeah, and I'll be gone for a couple of weekends, so
Uh,
but we'll muddle through all that.
yes, we will. So.
Okay, so today we want to talk about ADHD.
Yeah, the other week we talked about depression and we talked about it from the perspective of, whether it's whether it's truly depression and what how medications respond, how they depression symptoms respond to medication and some of those things. And yeah, I think we're gonna kind of introduce and start talking about the same thing as it relates to ADHD today.
Exactly. The points we made with depression is that um, depression can be either biological or it can be about your life circumstances. Okay, it can be either one. And the other thing is the pathophysiology of depression, where it is in the brain and how the brain works, has never been articulated. We
Right.
simply don't know. And we can't confirm. Everybody says it's the serotonin hypothesis. It's because you have low serotonin. That's really never been confirmed.
Right.
We think that that's what the problem is, but we don't know, and it's never been confirmed. And most alarming of all is that the research, careful research over time, indicates that antidepressant medications are of negligible value for many, many people, not all people, but many people who take them. And they probably just provide a placebo effect. They're not as effective as we once thought they were. And then we find out that maybe the same questions and the same assumptions are being made about ADHD.
Right.
And maybe it's time to take another look at this. And this is what Paul Tough did in a great article in the New York Times Magazine. Now, Paul Tough, you may recognize his name because he wrote a wonderful book in 2012 called How Children Succeed.
Mhm.
And it's still relevant today. So, this is a guy who does his research. He's very careful, very thoughtful. And he wrote this article in the New York Times Magazine titled, Have We Been Thinking About ADHD All Wrong? And what he does is he reviews the research that has been done since we first started to treat ADHD as a medical diagnosis.
Right. And so he asked that same important question, the same important question we asked with depression, is ADHD a brain-based disorder? And I know that you and I have historically we've always referred to ADHD as a neurobiological
We
brain-based
were taught, that's
disorder.
right. That's what we grew up in that tradition.
Right. And so, so it's really interesting how he presents the information because, he writes it for people with ADHD, for parents of kids with ADHD, and, really anyone with ADHD or without ADHD who may be taking stimulant medication or, maybe considering stimulant medication. And so it's a really well-written article. And of course, the link to it will be in the show notes, but it's just really important information. And, as we get into this, I think it's, as we often do we want to start out by talking about ADHD sort of in a historical context, because, I think that Richard, you've probably heard lots of patients say, well, ADHD wasn't around when I was a kid.
Right.
Well, I think people will be surprised to know that it's the idea of ADHD has been talked about for a very, very long time.
hmm Yeah, for thousands of years.
Yeah,
Okay.
back to ancient Greece.
Right. Because if we're going to question all of the assumptions that professionals have been using for, gosh, 40 years,
Mhm.
at least 40 or 50 years about ADHD, stuff we talk about every day, if we're going to question those assumptions and say, wow, how did we get here to start questioning what we've been doing for a long time? it helps to know that history. And the
Hmm.
history of ADHD goes back, the earliest references from ancient Greece. I mean,
Yeah,
Socrates and different philosophers talked about these kids who are described with the same symptoms as ADHD. And then you can go back more than 100 years to physicians in England who talked about ADHD as an abnormal defect in moral control. And
right.
that resonates with anybody who's dealt with a child with ADHD.
Right. Yeah,
So,
I don't remember the character's name, but wasn't there was a German cartoon
fidgety,
character.
fidgety Phil.
Fidgety Phil. I knew there was some
Yeah.
alliteration to it, but yeah, Fidgety Phil. And it talked about a kid who couldn't sit still and was very fidgety, and that was a long time ago.
But our story, the story that we want to start talking about today, really begins in 1937. And you have mentioned this frequently on the podcast, was when Charles Bradley, a psychiatrist, accidentally discovered that benzodrine, and benzodrine is a kind of amphetamine, it's sort of like a stimulant medication, reduced behavior and learning problems in children who were in a behavioral disorders unit in a hospital, in an agency, in a residential setting. And he gave them, he was using benzodrine to treat headaches.
Right.
And he accidentally discovered that, wow, it does this. And that's really the beginning of using medication to treat ADHD.
Right.
Now, if we go up to 1968, that's the second edition of the Diagnostic and Statistical Manual. All that's mentioned is hyperkinetic reaction of childhood or adolescence and organic brain syndrome. And that's all it says. It doesn't describe symptoms. It doesn't
Right.
say anything else. It just lists this as a name, doesn't give any more information. But that was in 1968. By 1970, the Washington Post reported that 5 to 10% of school children in Oklahoma were taking Ritalin.
Right.
So within a couple, now, Ritalin was first used in 1955.
Right.
So, but it wasn't until 1968 that we even had a name for this
Right.
in medical literature. And in 2 years, we have 5 to 10% of kids in Omaha are taking medication to reduce ADHD symptoms. Okay.
Right. Yeah. So it took off very quickly once we had a name for it.
Right. And
And
then
that's sort of the power of names, right? Once you start to identify something, then starts to take off.
that's right. So by 1980, now we have a name. Now that's the first time we used ADHD. Okay. So go back to 1980. But the real impetus happened with the revised edition of DSM-3, because by 1987, DSM-3 has this diagnosis. The American Academy of Pediatrics issues guidelines for medication. But at the time, there were only three medications to
Right.
choose from. Okay. So that was the state of the art in 1987. So it's around 1990 that how we think about ADHD and how we treat ADHD began in about 1990 with the work of a group of researchers, and one of them is named Jim Swanson, and we still use one of his tests. The SNAP is one of the tests he developed, and other researchers who wanted to study DSM-3. Here's this new diagnosis.
Hmm.
People are taking medication. Let's take a closer look at it. So Swanson and a group of researchers put together what was called the multimodal treatment of ADHD study. It's called MTA. Now, at the time, about 3% of children were diagnosed with ADHD, and that's important. That's an important number to remember. So, in the beginning, 3% were diagnosed with ADHD. So, the multimodal study was 6 sites. There were 100 kids at each site, and they were divided into 4 groups. One group took Ritalin, one group did behavior training, one group did a combination of medication and training, and one group had no interventions.
Right.
Okay. After 14 months of treatment, so through the 1990s, they're studying these kids. And one of the conclusions they reported, one of the findings they reported, was that after 14 months of treatment, the Ritalin group had fewer symptoms.
Hmm.
Now, as you might imagine, that sets a firestorm,
Right.
right? so the effect of that is that now more drugs are being prescribed. So prescriptions increase. Also, this is what led to the search for different kinds of compounds, particularly those that would last all day. So
Right.
when people take extended release or sustained release, it was it was spurred by this research in the 90s to create better and more effective drugs that would last longer.
Right.
Okay. Because so you didn't have to take them twice a day and take them at school.
Yeah, and it's so weird to think about that. That was 1999,
Yeah.
that when some of those conclusions came out. And it doesn't feel like that was all that long ago because I
Right.
started grad school in 1999, and but I guess it was 26 years ago. But yeah, so after that, you started seeing this explosion in the number of prescriptions that were written for ADHD and for some of
Mhm.
those behaviors, and obviously, as you said, it triggered this search for medications that could last longer because prior to that time there was only the medications that were used were short acting. They were only
Right.
so 3 or 4
Mhm.
hours, and that was why around lunchtime during the school day, there were certain kids who had to go to the office to take medication, and it's
Right.
because they took their Ritalin or Adderall first thing in the morning before school, and then by lunchtime they needed their second dose to get through the rest of the day. Um, and so,
And schools had to keep this Schedule II drug locked up in cabinets,
right,
and they didn't want that responsibility. So the drug companies responded by creating these sustained release or extended release compounds.
right,
But what we see, so we see this explosion of new medications, but also we see a dramatic increase in the rate of children receiving the diagnosis.
right,
So remember, we said that in 1990, about 3%. By 1997, it was 5.5%. By 2000, so in that decade, 6.6% of children. So it's almost it more than doubles.
right. So from 1990 to 2000, it went from
Mhm.
3% to 6.6%.
Right. And we go from three medications, and today we have 36. And I didn't realize that. There are
A lot.
36 medications that are used for the treatment of ADHD. Now,
Yeah.
not all of them are stimulants, but that's still, we go from three drugs to 36 drugs. Point is, in this 10-year period, there's an explosion of ADHD research, treatment, drugs,
Mhm.
everything. Okay. And most of all, the increase. Now, from from 2012, so let's go into the 2000s, to 2022, prescriptions increased by 58%, but they tripled for adults. Okay.
Right.
So by 2022, children are now, there's 11.4%. So now we've gone from 6.6%. In another decade, we double again, and we're at almost 12% of children are getting the diagnosis. And adults are now at 6%. It was almost nothing
Right.
in late 999 and early 2000s. It was a small number of adults. Well, by 2022, 6% of adults, and that's increasing. So the rates have tripled in adults. They've doubled in children, and they've tripled in adults in that 10-year period from 2012 to 2022.
Yeah, and it's important that we sort of differentiate just a couple of things before before we wrap up for today's podcast. You know, it is really difficult when we talk about ADHD in adults. In the 90s, I don't even know that people talked about ADHD in adults because early on, from the 80s when ADHD was first named to 2000 and a little bit into the 2000s, for the most part, people believe that ADHD disappeared in adolescence. I remember
That's
people
right.
people talking about, if you could just get through elementary and the start of middle school, it's going to be okay because ADHD goes away in most kids with ADHD, and it's going to be
Because we didn't think it
okay.
existed. We didn't think it existed in adults.
Right. It was in a category in the DSM that was disorders of childhood and adolescence. It
Right.
wasn't in
Mhm.
it wasn't really thought of with adults. And I think that there was a very small percentage of people who it was believed carried those symptoms on into adulthood. in the 2000s, as that research, from the MTA research and other research that was done, we started to see that no, these symptoms do continue. They
Mhm.
just sort of morph and change just a little bit. And so ADHD, in particular, like hyperactivity, looks very different in an adult and teenager than it does in a child. Because whereas a child doesn't sit still, they keep getting out of their seat and walking around the classroom and those kinds of things, teenagers and adults report an inner restlessness, and so they feel a little bit more fidgety, and they just feel like they have to get up. They have a little bit more control, but there's this distractibility that comes from this internal drive, this internal urge to get up and to move, and they have that inner restlessness, and they just feel like they have to be doing something all the time. Um, so it's interesting how some of that has shifted, and now we do a lot of ADHD evaluations in adults.
Right.
And again, in
Oh
the
yeah.
early 2000s and in the 90s, we didn't do evaluations of ADHD in
Right.
adults really.
Right.
It was almost always in children, and almost always in like second, third, and fourth graders.
Right.
It's like those were the kids that we evaluated.
Right. I don't remember I remember treating this in the late 70s. I remember it was part of our work in a hospital setting, in a pediatric setting, but it was a teaching hospital, so they tend to be ahead of the curve. But clearly in the 1980s, we were treating ADHD. Okay, we
Right.
had a name, we were treating it. And by the 1990s, when I went back to graduate school, I went back in the early 90s, you went back in the late 90s. So in that 10-year period, we now have a name and we have studies. I went to the University of Georgia then to do MRI studies,
Mhm.
looking for structural changes in the brain of kids with ADHD. And so there was this explosion of research, and it really started in 1987 when we had an ADHD, and we had two or three types of ADHD, and that spurred this research.
Mhm.
And the most important part of that research, what Tuff is saying in his article, was this multimodal treatment study because that was a very thoughtful, very well designed. It was across settings, had a large number of patients, and they followed them long term. And
Mhm.
that was the good. They were able to follow these kids from age 7, 8, 9, and up. And they studied it over the years. So what we learn is how we think about ADHD and how we treat ADHD is based largely on the results of the multimodal, multi-site study.
Right.
And all of us did that. We just talked about ADHD the same way, that we give these medications and they wear off by 2 or 3 o'clock. And this is how we treat the disorder. This is how we diagnose the disorder. And we all sort of did similar work based on this study.
Right.
The other thing that happens is in this same time period from 1990 to 2000 and then 2000 to 2010 and up to 2022 is the most important finding, I think, and what we want to emphasize is that rates triple
Right.
in that same time period from 1990 to 2022. Rates triple, but they triple in children. They go from 3% to almost 12%, and they triple in adults. So what we see in 1990 is 3% of children have ADHD, and there are three medications. By 2022, almost 12% of children have ADHD, and there are 36 medications.
Right.
But we have to account for that explosion. And I think the explosion was from this preliminary data from the MAT study. Now, the second chapter that we're going to talk about is in the second part of this podcast, which we're going to record later. But we have to explain this.
Right.
How did we get to where we are today?
Right. Because I think part of the argument is, first off, 12% of kids is a lot of kids. And
You
and
think,
so we have this huge number of kids with ADHD who have been diagnosed with ADHD, and
right,
we have this the huge use of stimulant medication. These medications are used very commonly. Not a lot of psychiatric and behavioral medications are prescribed by psychiatrists. Well, stimulant medications are often prescribed by pediatricians and general
Exactly.
practitioners. And so, and not that there's anything wrong with that, but it's just to illustrate the prevalent use of them and how, how just how many people are taking these medications.
You,
They're just so available.
the other anybody who is using these either if you're using them, if you're an adult and you're using them, or if you have children who are using them, you probably encountered times when there were no medications available. The
Mhm.
drugstore was out of the medication, right? I think the reason that happens is because the manufacturing of drugs is based on the percentage of people who have the diagnosis.
Mhm.
And so you don't want to, if you have a 10% of people who have a disorder, you don't want to build medication for 40%
Right.
because 30% is going to go unused and you're going to throw it out. And
Right.
it's a cost. It's an unnecessary cost. So I think what's happened with ADHD is the diagnostic rates have increased but the medications are not increasing with it
Right.
because the medications are designed for 5%, and here we are at 12% prevalence. So yeah, we're going to run out because they're not making enough medication for all
Right.
the people with the diagnosis.
Right.
You,
Fortunately, those folks that were doing the MTA study,
Mhm.
fortunately, they continued their research.
Right.
And while much of what has happened so far is based upon those preliminary findings from about 25 or so years
Mhm.
ago, um, Paul Tuff, he talks about in this article some of the ongoing research that's been done, and that's what we're going to talk about in part two of this podcast.
Yeah,
You know,
because
to date.
this Jim Swanson, who we mentioned earlier,
Mhm.
he's now 80 years old. And so he's at the end of his career, and he's one of the people who is saying maybe we ought to rethink this whole thing. So the reason I like this article is the people who did the research that led us to this point are now they've continued to do research, and they're saying a different picture is emerging. And so in part two, we want to talk about that different picture.
All right. So
Okay.
that's it for today. We'll be back to talk a little bit more about the next chapter. So until next time, stay happy, stay healthy, and forget to be afraid.